All right, we will go ahead and begin now. Thank you everyone for joining. My name is Tanya and I work for Haag-Streit. I am the Director of Specialty. We'd like to welcome Dr. Pinakin Davey. He is a tenured professor at Western University of Health Sciences College of Optometry. He holds a Doctor of Optometry degree from Southern College of Optometry and a PhD from Anglia Ruskin University in Cambridge, England, in the area of glaucoma. His postdoctoral research fellowship at University of Louisville was focused on improving imaging techniques in glaucoma. Thank you for joining us this evening, Dr. Davey. I will go ahead and hand it over to you.
Thank you very much. It is a pleasure to be here. Thank you, Haag-Streit, for putting this together. I see the attendee list growing. Hopefully more will trickle in. I see some friends in the attendance. To all of you, hello, and thank you for being here, and let's get started. The idea is that we could talk about perimetry and how glaucoma management is truly aided using a perimeter. One of my favorite graphs in life is to actually talk about Joseph Caprioli's paper, where he talks about, it's a very theoretical idea. Nobody really knows when glaucoma truly begins. The risk of glaucoma indeed increases after the age of 40, but we really don't know when it started. So assuming that we know two solid dates, we know when we are born, we don't really know when a person's going to pass away, but we want to maintain vision until the last day and usable good vision until the last day. And if you're following a trajectory or progression that is extremely slow, let's say you have the patient has the disease, but it's so slow that they would most likely die before they ever reach the level of disability, then you have nothing to do and nothing to be worried about. But in reality is all our patients don't follow that slower trajectory. If progression has begun or worsening of retinal nerve fiber layer and visual field has begun, then you have to change or intervene and change the trajectory. If you intervene very late or you identify something very late, well, that's not going to work really well because one would face level of visual disability. Whereas if you intervene early and appropriately and catch it, then the intervention will work and you will save useful vision till the last day. So early detection and prompt treatment truly saves irreversible vision loss in glaucoma. And glaucoma, kid you not, it is at the moment irreversible. We don't even see a horizon for cure for glaucoma anytime soon. And the other thing we need to remember is glaucoma is a blinding disease. If let to run its course, glaucoma will lead to blindness. So we need to stop this ugly beast. So that's why you need early intervention, appropriate intervention to change the trajectory, and various devices help us in our case. We all love our OCTs, we love our structural devices, and the major premise that structural damage precedes functional damage in glaucoma comes from the fact that we know that the retinal ganglion cells die in the retina, and then subsequently you find photoreceptor cells actually die, and then the axons of the retinal ganglion cells that move towards the optic nerve and the brain also die. So we know that structurally there is loss of retinal ganglion cell. So the idea is that there has to be a loss of a structural loss of a retinal ganglion cell before functional damage occurs. Now, is that always the case? And the answer is not likely, and actually pretty sure about it that it's not always the case. Here's an example from Oates' study, which showed that 55% of ocular hypertensives showed the first sign of progression to glaucoma in the nerve. 35% showed visual fields as the first sign, and only 10% showed both simultaneously. So in reality, if you just use structural techniques, you'll probably catch 65% of the patients. If you use only functional techniques, then you will probably get about 45% of the cases. You really need both to actually get all the cases that are converting to glaucoma. So first myth to bust here for tonight is that structural loss doesn't always precede functional loss. If you were to accurately measure individual retinal ganglion cells, and we know exactly how many ganglion cells we have, then that's a whole different story. But we are nowhere near that day. Continuing on, now let's assume that we like our OCTs. So here's a graph from one of my papers, and what I'm showing here is a group of people that are healthy and a group of people that have glaucoma. And now I haven't labeled which one is which, and it will be very difficult to say which one's glaucoma and which one's normal at a glance. The left on the blue panel is normals, and the red panel is glaucoma. Let's overlap these two on top of each other. And what we find is that in early glaucoma, particularly where not much damage has occurred, there is a wide range of overlap between early glaucoma group and healthy. So OCT fundamentally cannot 100% diagnose the cases in early levels of damage. You do require additional evidence when you try to catch these individuals. Now, as a standard of care, COVID has come, and yeah, we'll talk a little bit about disinfection techniques and what to consider, and you're welcome to ask me any question in that arena too, but glaucoma care is glaucoma care. COVID or not COVID, you need certain tests done. We do visual fields, we do structural measurement, and we do this in a safe fashion that is safe both for the practitioner as well as the patient. So the threshold tests are a standard of care. Now you want to do a threshold test that gives you central visual field accurately. You could do something like a 30-degree protocol of like G protocol, which is my favorite protocol these days. I have converted all my patients to that strategy because I'm convinced that the glaucoma protocol actually is better, and hopefully I'll be able to convince you as to why that is the case. So G protocol, or if you're used to a more conventional protocol, you could use a 32 protocol or a 24-2 or a 30-2 protocol of visual field. Now, but the central protocol is what we actually truly measure. So a fundamental question is a very fair one to ask: is glaucoma a peripheral disease? And the answer is definitely. Glaucoma is a peripheral disease. So then why don't we measure visual fields from 30 degrees to 60 degrees? Why are we only measuring central visual field? Well, the answer to that question is that we are not so good at doing threshold perimetry or any sort of threshold task in the periphery. Our retina is just not used to finer details when we come to the peripheral vision, the extreme peripheral. So threshold testing will not work. So if that's the case, then we know that it is a peripheral disease, but we are measuring visual field centrally. And we also know that central vision is sort of more protected in glaucoma. Is that true, or is that just something that we have believed as a dogma? Well, the answer is yes, there is some truth to saying that the central visual field is a bit more protected in retina, particularly in patients with glaucoma, because what we know is that the retinal ganglion cells, axons, that travel from the central all the way to the optic nerve head, mix with the peripheral fibers as they go through the optic disc, lamina propulsa. So yes, the central fibers are a little more protected, but it is certainly not as much as once considered. The mistake that we did was we assumed that visual acuity is 20/20, so the central vision is okay. And the reality is it's not the case. You might find visual acuity may remain 20/20, but many other functional tests becoming worse in patients with glaucoma. And now with OCTs, there are so many OCT studies that have identified macular damage early in glaucoma. Then why is it that we still don't see too much damage centrally? If you're using a Humphrey 24-2 protocol, which has enjoyed its supremacy for a long time as a go-to test that everybody likes to do, well, only has a very few points in the central location that actually measures visual fields in the macula. So you have about the central 4 points and maybe just a little bit more measuring the macula. Now, if you had such little representation, it's unlikely that you're going to find the problem. If you used a G protocol, which has a much more denser, high resolution central perimetry performed, then you could indeed identify defects much earlier. So G protocol, so I'm trying to build evidence why G protocol is the protocol to go towards. And this is the first step, that it has a better resolution in the macular region, which may correspond very nicely with your OCT findings. Now let's take this a little bit further. What good is a visual field test which has a lot of reliability issues? And we have patients that are usually, the mean age of the population of glaucoma is around 60 years of age. It can start as early as 35s, 40s, but when you look at the whole population, they are older, 60 years of age, approximately. And these individuals have probably never played a video game in their life, and you're giving them a video game and saying, all right, let's play this video game, and we are going to make the target extremely difficult. So we are raising the challenge to almost, it is that you can only see it 50% of the time, because true threshold means that you will see the target 50% of the time, and you will not see the target 50% of the time. So we're making it so difficult, so it becomes a very tough test. Now, fixation losses, false positives, false negatives, all these need to be as low as possible. In fact, fixation losses should not exist. Given that today we have ultra-modern eye tracking devices that can actually measure in less than 1/10 of a degree to actually, with that level of accuracy, fixation losses should not exist. And so Octopus Perimeter uses true tracking of fixation loss. And what it does is that if you actually align the patient up, if the patient has an eye movement, then the machine would readjust itself to the right location. First point. So you have to less fuff around playing with the positioning of the patient. Second part of it is, because of this, you don't have to interrupt or stop the patient or refixate the patient. It's a huge advantage. So less interruptions means quicker test completion. And if the patient actually closes their eye or accidentally blinks, which is entirely possible, it's about a 5-minute test, you are going to surely blink multiple times. And what if the projection of light occurred right at that time? You will miss it, right? So if the machine catches a blink, it will recheck it, as well as if the patient just closed their eyes, the machine would pause the test, which is so useful because I'd much rather have useful data than a whole load of garbage data that we can't use. So this really improves the reliability of visual field testing a lot. So Octopus Perimeter, true fixation, helps your clinical cause a lot. I will keep an eye on chat message. If you have typed a question or the question and answer box, please go ahead and do that, and I will certainly monitor the question and answer as well. The question and answers really helps the professors a lot because we get a chance to drink some water. I promise it's really water. All right, so, okay, we talked about fixation losses and how that is important. Second part of it is that as I told you, in early glaucoma, the retinal nerve fiber layer is going to look very similar to healthy eyes. So does a patient truly have glaucoma, or is it just a slight variation from normality? So you need more evidence in early glaucoma, and you need to correlate multiple parameters to get your answer. So structure and function correlation is very crucial. And the second myth I'd like to bust is that structure and function don't correlate very well. Let's start by giving some examples and then going through the cause. So here you have a Humphrey visual field that shows, you can see that this person, you cannot see the numbers very well, but they're all zeros. And you can see from the grayscale that it is a pretty washed out visual field. And this is, and you can look at the fellow eye, the right eye, shows some level of definite arcuate scotoma. You're actually seeing that occurring superiorly. So you would say, all right, the left eye is completely blind, The right eye is having early glaucoma. And that would be the case, right? Then you go, let's go to OCT on the same patient. And you can find that the nerve fiber layer is so close to each other, barely different. So let's go back. Did I really see that correct? It's early glaucoma by visual fields, and the nerve fiber layer is pretty much the same. Well, what would cause that? Well, it's easy to point a finger and say structural function differences are the cause. But however, we also know that when we look at structure and function, in extremely early glaucoma, the visual field tends to have a lot more redundancy, and we may find that the nerve fiber layer may show a little bit of changes, which doesn't match very well with visual function. And in advanced cases of glaucoma, where the mean deviation is in the areas, or mean defect is in the areas of 30 or so decibels, you might find they don't correlate really well. So I gave you an extreme example and said it may not correlate. But for the majority of the cases in the middle of the range, where you can see that this is about 3 decibels or so in loss, and up to about in 22 decibels or so, you actually see that the structure and function correlates really well. That you actually would see a proportionate loss of visual field with a proportionate loss of nerve fiber layer. So in true estimate, structure and function are not polar opposites, but they are actually very close and mirror each other if the testing is done appropriately. Now, if you had to correlate structure and function, and you've seen this Ted Garvey-Heath plot, if you know the region of damage in the optic nerve, then a corresponding damage occurs in the visual field. So for example, the infratemporal region loss nicely corresponds with the superior visual field in the arcuate bundles, and so on. Now, this is very difficult to do as you are trying to do this in busy clinic. So let me go through certain unique features of Octopus that helps your cause a lot, and then we will wrap this up with a few cases as well, and we will talk about that. So here are some unique features of Octopus perimeter. The first thing that is unique to Octopus perimeter is actually the polar graph. The polar graph, if you have a visual field defect, as seen here in the superior region, you have a corresponding plot that is created of the visual field, telling you where are you likely to see the damage in your optic nerve head or nerve fiber layer. So a superior region defect like this should correspond to an infratemporal loss right here. And you can actually see that this can correspond nicely with your fundus photograph. Let's go back one touch. You can see a nice notch being formed right in this region. At about 5:30 in the rim tissue, you are seeing a nerve fiber layer defect corresponding inferiorly. And this, the polar graph corresponds very nicely to what was actually present. So on the left, you have a predicted plot from the visual fields. And here you have true structural damage that you can correlate. So the polar graph indeed bridges the structure and function gap. All right, so then going on further into this is to talk about cluster analysis. So you look at a whole visual field, 30 degrees, you have various points that you are testing. Cluster analysis groups the visual fields in 10 different regions, okay? So you have 10 different locations that the cluster analysis groups them. The idea is that individual points may fluctuate a little bit, but the cluster together actually is very stable. So in the superior cluster right here, you have multiple points, and those individual points may vary, but overall that cluster should be quite stable. Second reason why it does this is to give you a little bit of structure and function correlation. These clusters are exactly the region that can be correlated with the nerve fiber bundles in your retina. So it can allow you to do some structure function correlation as well. Let's take a case from the Octopus book by Gabor Hollow, a longtime collaborator, and we have published numerous papers together. So this case, Gabor Hollow is trying to show that here you have in grayscale a paracentral defect being visible. And if you look at the probability plot, you have two spots right here in the paracentral region showing outside normal limits where the p-value is less than 5%. So definitely suspect, but not a large enough region that falls outside the probability of less than p less than 5%. You have a couple of points, but if you did cluster analysis on them, you're going to find the entire cluster is decreased by 2.3 decibels, and which is showing you that p is less than 1%. So you get a lot more robust results in glaucoma management, and you won't fall in trap with a spurious one-off point showing outside normal limits. So this is allowing you to be a bit more confident that this paracentral defect that you're seeing is not a fluke, but a real defect occurring. Let's take another example from the book as well. And you're seeing that here, right here, in the same case, that you're seeing the paracentral defect being shown in the cluster analysis. The polar analysis is showing a predicted infratemporal defect. And you can see that right here on the fundus image at about, you're seeing a small hemorrhage at about 7 o'clock position and a subtle nerve fiber layer loss. But if you then went ahead and did an OCT of the macula, you're seeing a nice defect forming in the papillomacular bundle, and you're able to see this nerve fiber layer loss. So you can actually group a few things: grayscale, probabilities, cluster analysis, polar analysis, and now throw in the fundus imaging or OCT map and get a little more correspondence. Let's take another case of an early glaucoma, primary open angle. Again, you're seeing a little bit of central defect. It's mainly in the superior region, along with a potential that you actually see some paracentral defect as well. So central, paracentral defect. You did the cluster analysis. Well, you say, wow, that's a lot more region that is flagged as abnormal. Now, the BEBIE curve is definitely showing that you have a local defect. And we'll come to BEBIE curve shortly. You're able to see infratemporal loss or predicted infratemporal loss on your polar analysis. And if you take the OCT findings, it shows you GCC thinning infratemporally, and this would correspond to your nice nasal step kind of thing that is seen in cluster analysis. So combining the cluster analysis along with polar plot indeed can help you identify some of these early cases of glaucoma. Now, BEBIE curve is a fantastic analysis that is only available in the octopus perimeter. Hans BEBIE did a very elegant analysis of actually just very simply grouping the best seeing points to the worst seeing points and just ranking them. So we know that there is a hill of vision. We all have heard that in glaucoma courses. And then we see periphery going down. What is this hill of vision? Well, hill of vision means that centrally we see the best and peripherally we don't see so well. So you have a hill or a peak in the center. Now, assuming the central location is supposed to see the best, that will become the best seeing point, and the worst seeing point would be in the tail region right here. So the idea is that you just rank points from best seeing to worst seeing, they should follow a particular pattern. So let's start with, let's take this one. If you have the best seeing point and the worst seeing point falling between these two lines, then the curve is normal, meaning the patient does not have any overt defect. If they have a diffuse loss, and the diffuse loss could be because of pupillary miosis or cataract, what you find is that the curve is shifted below, but it is parallel to the lines of normality, meaning that this is a diffuse curve, or a diffuse defect. Beg your pardon. This is a if the BEBIE curve is shifted parallel, then it's a diffuse defect. And now when you actually start seeing, let's see example of a local defect. You have the BEBIE curve pretty much within the ranges of normality, and then suddenly drops down, which means that majority of the visual field is normal, but then there are certain patches that are starkly abnormal. And here's an example, which is what most glaucoma cases would be, is that you could see some level of diffuse defect and some amount of local defect. So let's take this. Let's go back to this. Here's an example of a patient who has purely just cataracts. Okay, that's a diffuse defect. It's running parallel to the lines of normality. And here you're seeing a patient with some amount of cataract, but some amount of glaucoma as well, where you're seeing a portion of the defect is diffuse, but then you have a more localized peripheral drop-off as well. All right, so BEBIE curve is also one of the unique features of octopus perimetry. Let's go into certain other strategies and tactics, and our favorite is the octopus PULSAR perimetry that can help you in identifying glaucoma very early. So let's take octopus PULSAR. Now you look at this and say, interesting, where is the bowl of the perimeter? Well, it doesn't have any exposed parts. The entire electronics is fully enclosed, and the patient and this perimetry can be done in regular lighting. You don't have to shut off the room lights or excessively dim the room lights, and all contents and parts are internal. Octopus 600 PULSAR perimetry really is groundbreaking in that respect. So let's talk about a little bit about disinfection, and I will talk both about Octopus 600 as well as Octopus 900. Now, as a standard rule, any hard surface or plastic surface that is available that can actually be disinfected with isopropyl alcohol 70%. And now you might pause and say, why are you being stingy? Why don't we just use isopropyl alcohol, 100% isopropyl alcohol? Well, you can do that, but there's a small problem. The problem is that isopropyl alcohol 70% penetrates the microorganism cell wall much better than isopropyl alcohol 100%. So you're not being stingy by using 70% isopropyl alcohol. You can actually penetrate the microorganism barrier much better. So external surfaces, wipe with isopropyl alcohol 70%. And if you are looking at a bowl perimeter like this, and if somebody has accidentally coughed into your perimeter bowl, then use soap suds to do spot cleaning, but don't rub on the internal bowl. Because if you actually sprayed something in the internal bowl or actually rubbed it hard, the inner coating goes away, and the inner coating is very crucial to keep the luminance level of your target appropriate. If the coating is disrupted, or if you have fingerprints all over, then you are probably not going to get good perimetry, and nobody can guarantee that. The second part is that there are perimeters that actually recommend that you need to spray the internal surface after each patient. And they recommend that because they have a fan blowing air outside. And so what happens is, in those perimeters, when the air is blowing outside, you have a greater chance of actually rotating or circulating the aerosolized particles. So those perimeters need the bowl to be sprayed. Octopus 900 does not need the bowl to be actually sprayed. And in fact, don't spray the bowl, because it would actually, any bowl for that matter, the coating is very important. Now, when you think about Octopus 600, the entire thing is enclosed. It is all plastic. Just wipe it down. Wipe it down and let it air dry. That's the best way of doing it. Now, if you are doing 900 perimetry with Octopus 900, then ask the patient to wear a mask, take the top part of the mask, and that's very crucial because you could fog the lens holder. If you're fogging the lens in the lens holder, you can create artificial defects which may not be explained by pathology. It's completely because of the fogging of the lens. So make sure you wear the mask and tape the top part to avoid any fogging. So these have become standard protocols, and We are actually a well-oiled machine, and the patients are safe, the doctors are safe, everybody's safe. All right. Now, I said that Octopus 600 is indeed a favorite. Well, because A, it's a compact design, and it does everything that a glaucoma or anybody that is only interested in static threshold perimetry can be done. And with also the advanced testing of targeting specific ganglion cell axons. Now, when you look at targeting specific ganglion cell axons, well, you all know from Vision Science 101 that we have about 20 odd different kinds of ganglion cells. But we don't talk about all the 20. We don't even have names for some of these. We talk about parvo cells, conio cells, and magno cells, and that forms a 98% of your retinal ganglion cell axons. Now, perimetry has unfortunately used a white target on a white background. So it's a non-specific target. Any ganglion cell, so long as it's alive in a given location, can detect it. So it's not very specific. So if you actually see a white target on a white background, even patients have actually some death of ganglion cells. I'm not saying that they are particularly magno or particularly parvo, but even if you have the cells dying, so long as some cells are alive, this is going to detect the light source and say, I can see it. But what if you only selectively tested magno cells, meaning that the M cells? These M cells are few to begin with. They're only about 9% or so. And what you see is that in early pathology, if you have some cells dying, you can detect the pathology a little bit earlier. Let's take this stepwise. So why is this a ring-shaped stimulus? Well, the idea is that the pulsar stimulus has a ring-shaped pattern, and the target is undergoing from the black light to white and white to black. So it's undergoing counterphase flicker or counterphase change, not flicker, counterphase change, and you are actually going to see a ripple-like pattern in your stimulus. So you are changing the black to white and the white to black, and the patient sees a ripple if the person's healthy. If they're not going to see something, that's just dark. It's just they're not going to see the stimulus. So in the disease cases, you won't see the stimulus, whereas healthy people will see it. Patients find it quite easy to detect because it's a pretty large target, and it's quite comfortable for them to do this perimetry. Now, from this, you can actually change the contrast or increase the resolution, make them more tighter, or more displaced further apart. So this is more easy to see, like big, thick circles, and this is more difficult to see when you have tighter circles next to each other. So they could change the contrast to make it more brighter or dimmer, and they can do threshold testing. And what you find is that especially in early glaucoma, where you're not so sure that if the defect is real, or you have very minimal or probably no defect, but the nerve head doesn't sit right with you, if you do this specific ganglion testing like pulsar perimetry, you would find the defect earlier. So pulsar perimetry is specifically designed for early detection of glaucoma. If you have a moderately advanced glaucoma, then you don't need pulsar perimetry. You should be doing white-on-white perimetry. So it's designed for early damage, and it has some other advantages. First thing is it's more resilient to optical blur. We know that we do refraction, but it's not always perfect when you are actually trying to evaluate a patient for glaucoma. And so the refraction may be a little bit off. Well, pulsar perimetry is more resilient to the optical blur. Second thing is cataract-related blur also is more resistant because the magno cells are more resilient to sort of generalized blur due to cataract. This may indeed identify early glaucoma. In fact, what we find is the patients show much larger defect on pulsar perimetry when compared to white-on-white perimetry, but make sure if you have a moderate or advanced glaucoma, you need to switch to white-on-white perimetry. Don't perform pulsar perimetry only, because you would get a much darker, pretty much a washed out visual field, black, and that's pretty useless. So moderate to advanced, do white-on-white perimetry, early testing where you're not sure if the person has glaucoma, you could certainly do PULSAR testing. Any questions at this point? Please go ahead and put that in Q&A. Let's take a case. This is seen in the last 6 months or so. Here's a case with early glaucoma, and this is a typical textbook case. There you're seeing with OCT in the right eye of the patient, both you're seeing certain sectors of nerve fiber layer outside normal limits. You're seeing the inferior nerve fiber layer is gone to borderline, and the superior has gone to borderline. Doesn't seem to follow the isn't true. You might actually guess there is a little bit of defect on the GCC, but not that much. Looks pretty solid for most part. You look at visual fields and say, that's pretty interesting. Let's look at the grayscale, some isolated few points out abnormal, and you're going to the BEBIE curve right here and say, that looks like a sudden drop off in the tail end, which means it's a localized defect. The probability plots are showing that there is a defect right here, and the corrected probability plots are showing the same defects, very consistent. So it's not cataract, it's a real defect. And let's look at the other eye. All right, so the other eye, well, the story ties nicely. You see again, inferior damage of the nerve fiber layer. And you're seeing here in the infranasal region, also there is some damage in the nerve fiber layer, and pretty much repeatable. You're seeing a superior arcuate kind of defect, and both the probability plot and the corrected probability plots are showing the same kind of damage with a sudden drop off in the BEBIE curve. So it's an asymmetric condition. The right eye, not so much damage, maybe minimal. Left eye, definitely showing you damage. So this was a textbook case of early glaucoma, and of course, this person is on treatment. Let's go into another one where we are looking at more features of octopus perimetry. So here you have, let's start with fundus picture. Fundus picture, you can look at this and say, healthy looking nerve, slightly larger cupping. I cannot tell if the inferior is the thickest. Looks to be pretty thick, but right here, if you look, this blood vessel is actually bending right here. So there is a little bit of elongation of cupping, with inferior rim not being the really thick like the fellow eye. Actually, it is significantly less than the fellow eye, and this might not even be meeting the isn't rule. So we get this as a first step, and then we say, all right, let's do some more testing on this patient. You do OCT on them, and you find that there is a superior and inferior loss visible, right eye. And you go to left eye, and you are definitely seeing a nice inferior loss in the nerve fiber layer. So let's go to this back again. Superior, inferior, supratemporal region, slightly outside normal limit, borderline case. And the fellow eye showing you outside normal limits and some region of borderline damage. Okay, now you go to visual field and say, that looks interesting. Scattered loss in a few places, but nothing that dramatic. Nothing that dramatic that pops out and says, all right, I should diagnose glaucoma in this patient. You look at the mean defect and PSD, you're certainly in the early stages of glaucoma, but nothing that dramatic. Okay, so now let's go and use the polar analysis on this patient. You find that exactly in the sectors that were abnormal or borderline, you're finding polar analysis showing you region of significantly outside normal limits. How do you know it's normal limits? Well, look at all these little stubby lines. These stubby lines are within the grayscale, gray region, so that's normal. But when the line extends outside the gray region, what it's telling you is that that is a significant amount of loss. And it corresponds to the region of your interest in your left eye, and to some extent in your right eye as well. You can see the supratemporal region, You have multiple lines outside the normal range, showing you an early defect. It's also showing you an infratemporal region, which the OCT at the moment is not showing you normal, not showing you a defect. So in this case, is this a case that the visual fields identified earlier than even a region of damage? Possibly. Let's look at OCT angiography on this patient. And here you have the right eye. Can't tell if there's loss in the capillary count. Pretty stable, I'd say. A small region right here. And in the fellow eye, you are seeing some loss, but nothing dramatic. So in overall, I'd say that there's a very good structure and function correlation in this patient. Yes, there's one region that did not match up, but that is pretty small amount. Let's take a case of ocular hypertensive. The patient is currently an ocular hypertensive based on conventional methods of thinking about this patient. And yeah, I got my 4-minute warning, so great. So you have the cases. Let's do this ocular hypertension case and then go into a few questions. All right, so ocular hypertension, by definition, pressures are elevated than 21, and you start seeing some level of OCT damage already, saying, all right, although it meets the isn't rule, all right, isn't rule met, inferior is the thickest, there is some region of outside the normal range in the borderline category. Visual fields actually coincides nicely with that. You are also seeing some infratemporal region potential loss, which is not confirmed. Is this truly a case of ocular hypertension, or was it a fluke, and this may not have been ocular hypertension? This might be early glaucoma. We don't know. You'll have to, of course, follow up this patient to see further, but what this definitely raised the suspicion to some extent in my clinical care that I would not necessarily just leave the patient be. And I would follow this up a little more closely, perhaps in the next 6 months or so, to see if they are going to convert. Certainly use the Oates calculator on this patient and see the risk of conversion. If the risk of conversion is high, then we'll definitely go for treatment. For this particular patient, even though the risk of conversion was greater than 5% in the Oates calculator, they chose not to get treatment, and so we will perhaps only monitor this patient. All right, to summarize, glaucoma is an optic neuropathy. Okay, so optic nerve head will get damaged. It is the most common optic neuropathy, but it's only one of many optic neuropathies. Structure and function does not always correlate 100%, but cannot be polar opposites. And it may have appeared to be that structure and function don't correlate really well because of inferior perimetric techniques that we utilize in prior studies. If we had performed certain specific strategies of aligning up the visual fields to the nerve fiber layer, we may have actually seen much better correspondence. Polar analysis and cluster analysis are of great value, and if they become standard for me, you may require multiple testing and multiple times before you can diagnose glaucoma in a patient. And early glaucoma is tricky for everybody, but certainly having good perimetry strategy helps your cause. Something like PULSAR perimetry may even save the day in identifying a case appropriately. And diagnosis, when you consider moderate to advanced, it's probably easier and obvious, but that's not really where you have to show off. You want to show off when you are trying to play and figure out early glaucoma. You want to look at progression in all these cases and make sure that you do a good progression algorithm. And above all, do no harm. Perimetry should not be a torture for the patient, nor should it be a torture for the doctor. You want a good, reliable, repeatable, fast and accurate perimetry. And if you keep doing the same thing over and over again, following old strategies, you're probably unlikely to see development. And that's it. I will stop and we will take some questions. Okay.
It looks like we do have a couple questions here.
Okay.
One of them is, can I perform ptosis testing on an Octopus 600?
So ptosis testing, it requires you to perform two tests and show that that you have improved the visual field in the patient. So, for example, if you do a central 30-degree testing with taping the eyelid of the patient, and then you actually remove the tape and show a worsening of field. If you show about 15-degree improvement, then that is clinically certainly useful. And so that's the strategy I would like you to follow. Low vision testing is a very, so there's another question. Low vision testing is a very specific kind of testing for which Octopus 900 perimeter is actually the best perimeter that can do kinetic. In fact, it's the only perimeter that is truly comparable to Goldman perimeter. PULSAR perimeter is for early glaucoma testing, and so I would not use PULSAR perimetry for that. I would use PULSAR perimetry for diagnosing early glaucoma rather than in the advanced stages. Okay. Okay. Do you use what kind of lenses, and how do you? In the picture, you didn't see a lens holder, I guess. All right. So you could have you are using the lenses that come along with Octopus perimeter. So Octopus 600 does not have a lens holder like a conventional lens holder that we are used to seeing. Octopus 600 comes with magnetic lenses. They are pretty large size lenses that can be just placed on the eyepiece, and they actually stick due to its magnetic properties. And if you are having astigmatism that's very minimal, then all you do is ignore the astigmatism, because any astigmatism less than 1 diopter you can actually certainly ignore. If it's higher than 1 diopter of astigmatism, then you do need to account for it. You could certainly start by doing a spherical equivalent. And if you have something very severe, very high astigmatism, you can consider using a half-eye trial frame with the lenses in place. So I would use the 600 special lenses that are magnetic, that frees you from the trial frame, and certainly that will be the way to go. Are there any more questions?
Looks like we've answered the questions that we've had so far. If there's any other questions, I'll give each of you a few more moments here to type your questions in the Q&A, and we'd be happy to answer any questions that you have.
Okay, there is appearing to be one more. Okay, speed of testing. How quickly are the tests performed? Actually, the Octopus perimeter is pretty good at, in fact, testing faster than, if you're used to Humphrey testing, you find Octopus testing a little bit more faster in its strategy. So let's go the Octopus strategies and go through them. You have the dynamic strategy as well as you have the tendency-oriented perimetry. The dynamic strategy is what most glaucoma specialists would like to use, which would be a comparable, I wouldn't even call it comparable because it's special, it's much better than CETA standard. But if you were used to thinking of CETA standard, then dynamic strategy is the appropriate strategy. Now, the dynamic strategy is actually pretty high resolution, so gets the testing done down to plus or minus 2 decibels in its ranges. And so in that way, it gets down pretty close to the accuracy of thresholding. And the number of minutes it takes, about 4 to 5 minutes in glaucoma patients, is what is the appropriate time. In healthy individuals that do not have glaucoma, it could be done in about 3 minutes or so. But if you're actually having a early to moderate glaucoma, you're talking about 5 minutes to 6 minutes of testing. Okay. Brilliant. All right. Tanya, let me give it back to you.
Yeah, thank you, Dr. Davey. Appreciate you joining us this evening and hosting this webinar for us. Appreciate all of you joining us this evening and taking your time out of your day to listen to Dr. Davey share with you his words of wisdom.